Okay, it looks like everyone knows what it stands for.
Good,
So,
I can sit
Corey,
down.
I think you're done.
Okay, I can sit
So
down.
here we go.
It actually
Corey
does stand
McBride.
for all of those, but in this context, you're right. It's an entrustable professional activity. So here's my disclosures, and I have to stand here for 7 seconds. I don't have any financial relationships that pertain to these activities, but I've done a lot of work for several organizations in this area. The goals today are to really talk about, so people know the phrase EPAs, and they're really getting comfortable, I think, I hope, to some degree with this idea, but you kind of have to take a step back because EPAs aren't used in a vacuum. We're really talking about it in the context of competency-based education, so we're going to take a step back and talk about that as well, and then try to inventory what the Fellowship Council is doing in this arena, and then we're going to talk through how the Fellowship Council and its work, we hope, is going to work through a pilot, in this next year. So our goal is to take medical students as educators and turn them into general surgeons. And then at this fellowship level is really to take general surgeons and hopefully turn them into some sort of specialist surgeons. But what we've really figured out is not everybody takes that straight path. Some people, it takes them a little longer to get there, or they take a more circuitous route. But our traditional educational paradigm, where everyone did these time-based rotations, really was a straight line model. There were a series of required rotations, there were elective rotations, and everything was about the case log and getting enough cases, getting the index cases, getting those ones everyone wanted. But what we all know is that completion of a case doesn't mean competency in the case. Plus, the case log, for those of us who have reviewed lots of them, realize that there's a lot of bias related to self-reporting. It's all about, and there's a lot of subjectivity about how much did they do and what role did they play. We all know residents that unless they did skin to skin, they call themselves the first assistant. And we also know interns who have said that they were the surgeon in a Whipple. And it's like, that just didn't happen. I will use Bariatric Fellowship as the example because as a bariatric surgeon, it's certainly the one I'm the most familiar with. But the traditional Bariatric Fellowship is a 1-year fellowship, and competence was really defined by numbers. And these are the traditional numbers required in a bariatric fellowship. They were based on the types of procedures plus a certain number of preoperative and postoperative encounters that they had to have. But again, numbers don't necessarily reflect competence. The idea of a competence-based education, though, is not a new one. The ACGME has been trying to figure this out since about 1999. They created the 6 core competencies that we have been dealing with: medical knowledge, professionalism, and things like that. And then to try to make it easier for us to evaluate the competencies, they came up with the milestones. And then they came up with the sub-milestones and the sub-competencies. And in fact, at the residency level, we've been reporting milestones on every resident since 2013. So, I don't know about you, but if you sit around in general surgery residency, now we have our 6 competencies, we have our sub-competencies, we have all of our milestones, and every one of these steps was actually supposed to make this easier for us. But I don't know about you, but I don't find this easier. I find this harder. We sit around faculty meeting and we talk about our residents and we talk about our fellows, and you're trying to sit there and you talk about, well, can they do this and do they know this and how many score percentages do they have? And it's not necessarily easier because at the end of the day, what we're really asking ourselves is, do we trust them? And that's what we as faculty are really doing every day. Every time you do a procedure with them, or every time you send them to the emergency department to do a consult, you're asking yourself, do I trust them to do this alone? Would I trust them to do this on our family member? And that's really what we're doing. We don't sit there and say, they seem to know 75% of the score essential diagnosis. We look at the whole picture and we think, do I trust them to walk into the exam room by themselves? Do I trust them to start a case or do the whole case? Would I trust them to do it without supervision? And that's where this concept of an entrustable professional activity came along. At some point, as fellowship directors, we have to sign the certificate at the end of the year. But we don't see every patient encounter all year long, and so we can't see the entire picture. We have to parse it out into smaller bits, and that's what the EPA is. It's small pieces or things that we want to observe. So we have to look at our profession and we have to say, what are those things that they absolutely have to be trustable to do by the end of the year? Now, it has to be something that's essential to our work. So as a bariatric surgeon, what are those things that they absolutely have to be skilled at to do by the end of the year? So as a bariatric surgeon, there will never be an EPA on doing a colorectal anastomosis, because it's not core to being a bariatric surgeon, but it is core to being a colorectal surgeon. It has to be a specific knowledge or skill. You have to acquire it through training. There has to be an output, and it has to be measurable. So it has to be something that will show up during the year. It can't be something that is so rare that maybe one fellow sees it, but the other fellow will not see it during the course of the year. Or it only happens once every 5 years, and so it's not acquired frequently enough that it is seen on a regular basis. And this is not a new concept. I pulled from the original reference back in 2007 when Dr. Tenkate first described EPAs. So again, it's not a new idea. There's a few things, though, that it's not, because some people don't talk about this in necessarily the correct concept. And while we talk about it is a described activity, it can't be so narrow, like I said, that it's really never seen. It's not one big final exam. Hey, John, I'm going to do an EPA on a gastric bypass on you next Tuesday. And if the case goes really well, you graduate from fellowship. But you know what? If they leak, you fail and you need to do a 3-month remedial rotation. That's not what an EPA is. And it's not a checklist. So while eventually we're going to talk about the tools in evaluating the residents, and there may be some guidelines to help you figure out how they're doing, that includes some behaviors you want to see. It's not check, 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 they can do this, do this, do this. So, as I said, EPA was first defined in about 2007, and there are multiple groups that have been working on EPAs over the years. They first started describing them for medical students, and several of you may be at medical schools that are already using them for EPAs for students. Pediatrics started to use them, several residencies created them, and several of the primary care and other internal medicine-based specialties have been using them for a while. In general surgery, the American Board of Surgery has now written 5, and they're piloting them at the general surgery level. And the Fellowship Council and the American Society of Bariatric Surgery began using them. So ASMBS actually wrote the first ones at the fellowship level, but then the Fellowship Council really realized that they didn't want every society to have to write their own and write them in a vacuum. So what they decided to do is, instead of having every society write their own, what they would do is they would get different societies, subject matter experts together, and essentially create a menu of different EPAs. Then each society that sponsors a fellowship through the Fellowship Council could pick from the menu for the fellowships that they essentially sponsor. So, and that is the work that's going on right now. The EPAs that are going to be on the menu have been picked. They have been written, and we're now at the stage where what we're doing is we're writing what those behaviors will look like. So we're writing through what someone who is who's not maybe successful at it looks like, what someone who's maybe halfway through fellowship might look like, and what someone who is probably ready to start practice will look like. We started with bariatrics, hepatobiliary, flexendo, foregut, and abdominal wall. Thoracic and colorectal are now going to be in a later phase. The other thing we did is we decided on a 0 to 4 scale. If you read the literature and you look at it, some people went on a 1 to 5 scale, some went on a 1 to 4 scale. General surgery had settled on the 0 to 4 scale, so at the Fellowship Council level, we decided to use the same 0 to 4 scale that general surgery did, since most of us teach general surgery residents and fellows, and that way we would be using the same scale that they did, and we wouldn't have to sort of change gears depending on the learner that we were evaluating. And what we anticipate is either a deficient fellow or the average entering fellow would probably be somewhere in that 0 to 1 level. A developing fellow, so during the course of the year, would probably be progressing through, and you would either be directly supervising them or providing them some indirect supervision. But the ultimate goal is by the time they're practice ready, that they're ready to sign off on that certificate, they can do these cases without supervision. So many of you may have seen a version of this. This is courtesy of Rebecca Mintor, who's leading a lot of this work at the Fellowship Council. But the ideal will be, in general surgery residency, they will get education and background and foundation in all of these levels. But then, so for example, the ASMBS sponsors the Bariatric Fellowship. So they will probably pick EPAs, and I do not speak for the ASMBS. I'm making some educated guesses about the domains they may pick EPAs from, but they may pick some of the EPAs from several of the domains. On the other hand, and again, I don't speak for SAGES, but based on the cases that they've picked, SAGES is the sponsor of the Advanced GI MIS Fellowship that is starting in 2020. They may pick a different number of EPAs from some of the similar domains. And so while they may pick some bariatric ones, they may pick fewer. And this is the type of work that's being done. We are hoping to pilot some of this, potentially by this next academic year that starts in August. The EPAs are being written and they're being described, and we'll be ready to roll them out. But then at the end of the day, where the rubber meets the road for you as fellowship directors is you have to actually be able to evaluate the learner. We do want the learners to take ownership of their own education and competence. So the idea will be when they think they're competent to do it, they think they can do a lap gastric bypass, or they think they can do a ventral hernia or a lap Nissen, they need to approach you as an attending and say, I'm ready to be evaluated on this skill set. And they need to communicate that somehow. We are hoping that there will be some sort of phone or computer-based app to do that, and or a computer dashboard. If many of you are familiar with like the Simple app that general surgery was using for a while, and so maybe they can click something in the app and says they're ready, and then you get something on your phone that says the same thing. And then you can just answer a simple series of questions. What are you evaluating? Which level do they meet? Were they, was it observation? Was it direct supervision? Was it indirect supervision of a simple case or a complex case? Or are they really practice ready? And at the end of the day, you're just answering that question. Did you trust them to perform it independently? Now, whether or not you actually could let them perform it independently is, of course, going to be subject to your local hospital, bylaws, credentialing, and everything else. But would you have trusted them to do it if you hadn't been there, is really the question. And these are the levels again. So that's kind of where we are. And this is kind of a graphic that I like. What we're trying to figure out is if they're competent. But at the beginning of the year, this is all you know about them. You don't know if they're competent or not. So you're getting these little clues throughout the year. And some of them are EPAs. Some of them might be something like a B-Safe or an endoscopy model. They're the evaluations. They're the research project. They're things like FES and FUSE and FLS. They're how they're doing on their medical records. They're the op notes that you're reading. So you'll never see the entire word competence because you're never going to see every activity they do during the year. But you're just trying to see enough to put the picture together to figure out if they're competent, and you can sign the certificate at the end of the year. Well, this has been an incredibly long journey, and I can't possibly name everyone who's done all of the work, but I'm particularly grateful for the two task forces that I'm working, which are the bariatric and the flex endo task forces. But this is where we stand, and we're going to continue to do all of this work over the next couple of years. Thank you very much.